Welcome back. While understanding the initial diagnosis of asthma is vital, understanding the pharmacologic intervention used in both acute and long-term management of asthma is just as important. In this lesson, we will examine the common medications used both for acute asthma symptoms and daily asthma symptom control. By the end of this lesson, learners should be able to identify drug classes used in asthma management and common drugs in each of those classes. They should understand the basic mechanism of action and adverse effects of those therapies, and where each therapy fits in the overall asthma treatment plan. As a reminder, this lesson is not all-encompassing. It's meant to give you just the most high-yield information. For further information on asthma pharmacotherapies, visit the Resources tab on our website, where the EPR4 and GINA guidelines, as well as specific dosing information, has been made available. First, let's start with the clinical scenario. You are seeing Gina, a 10-year-old patient, in your clinic for asthma. After gathering a history and performing your physical exam, you diagnose her with moderate persistent asthma and prescribe her both an inhaled short-acting bronchodilator and an inhaled corticosteroid. Gina's mother asks why her child needs two different inhalers. What guidance would you give the parent about the role each medication plays in managing Gina's asthma? There are multiple pharmacotherapies used in the management of asthma. Listed here are the most commonly used drug classes. We will discuss the most high-yield information of each drug class to help you in your clinical decision-making. The first important point to understand is that not all asthma medications are used for all clinical scenarios. Some drug classes are used as rescue medications acutely when patients are having symptoms, while some are used daily to help prevent symptoms. There's one particular drug class that will be discussed briefly that can be used in both rescue and control situations as part of single maintenance and reliever therapy, or SMART. But a separate lesson will go into detail about this form of therapy. Lastly, there are other therapies listed here, such as long-acting muscarinic antagonists and leukotriene receptor antagonists. These drug classes will be discussed briefly, but they are often considered add-on therapies. You will likely encounter or even prescribe some of these add-on therapies at some point in your training or practice. Often, if a patient is requiring multiple add-on therapies or biological therapy is being considered, then subspecialty referral to a pediatric pulmonologist is likely warranted. For your reference, we have included a table with the common abbreviations we use when talking about these different drug classes. The first drug class we're going to look at are the short-acting beta-2 agonists. The most common drug you may see used from this class is albuterol, but there are others. These work by promoting bronchial smooth muscle relaxation. This class of medications has a quick onset of action and is generally used when patients are having acute symptoms. You may hear them referred to as quick relievers or rescue medications. Daily treatment with this class of medication is not recommended for asthma treatment. Side effects are generally mild, with tachycardia and muscle tremors being the most common. The second drug class we will discuss are the inhaled corticosteroids. ICSs are the mainstay of daily asthma therapy and are generally thought of as a controller medication that a patient takes daily to prevent symptoms. Common ICSs you may see include fluticasone, mometasone, and budesonide. They work by decreasing airway inflammation and mucus production. The onset and duration of action varies with which steroid used, but generally onset is within hours. True benefit, however, from daily ICSs may not be seen for several weeks. ICSs are also generally safe, with oral candidiasis and dysphonia as some of the most common adverse effects. At extremely high doses, however, adrenal suppression and other glucocorticoid effects can be seen. Inhaled corticosteroid dosing varies by age and medication used. See the Supplemental Material tab on the asthma website for specific dosing information. The third drug class we'll be talking about are the long-acting beta agonists. The only two LABAs approved in children are salmeterol and formoterol. They work similarly to the SABAs by promoting bronchial smooth muscle relaxation. Their onset of action is slightly longer than the SABAs, but the duration of action can be upwards of 12 hours. Adverse effects of this drug class can be serious, including an increase in asthma-related deaths, especially when used as a monotherapy. For this reason, it is recommended that LABAs always be used as part of an ICS-LABA combination therapy. The next class we will look at are the combined ICS-LABA class. As mentioned on the previous slide, LABAs must always be paired with an ICS to decrease serious adverse events. Some of the most common combinations you see are listed below. I consider this class as both a controller and a rescue because it can be used in both roles as part of SMART. This will be discussed in another lesson, but in SMART, instead of having one rescue inhaler and one controller inhaler, the same inhaler is used for both. Medications in this class work by promoting both anti-inflammation and bronchodilation. These medications can be used as both rescue and control inhalers because of their quick onset of action, more so with formoterol-containing products, and because of their long duration of action. Adverse events are again generally mild. A major benefit seen with ICS-LABA combinations is the ability to improve asthma control with the addition of a LABA without having to increase the steroid dose. The last drug class you may commonly see are the oral systemic corticosteroids. I consider its role in asthma therapy as a rescue medication, but specifically used in status asthmaticus. It works by immunosuppression, anti-inflammation, and decreases mucus production. Its onset will vary with route of administration and dose, but generally takes hours before its full effects are seen. The adverse effect profile of systemic steroids are generally more serious than the other classes we've examined, as higher or repeated courses can cause adrenal suppression and other glucocorticoid effects. There are other pharmacotherapies used in asthma that are considered add-on therapies or alternative therapies. In the table provided are examples of 3 different classes. Leukotriene receptor antagonists and muscarinic antagonists are generally used as add-on therapies and are not meant to replace daily ICS or ICS-LABA therapies. However, short-acting muscarinic antagonists such as ipratropium, also known as Atrovent, can be used as a rescue medication in some cases, such as patients with bronchomalacia. Biologics are reserved for severe asthmatics and are usually managed by pulmonary or allergy subspecialists. So, let's go back to our clinical scenario. You prescribe Gina both a SABA and an ICS. What guidance would you give mom about the role of each medication in Gina's asthma management? You can tell mom that the ICS is her daily controller medication meant to help prevent symptoms, while her SABA is her rescue inhaler, not meant to be used every day, just when she is having symptoms. As we end this lesson, it's important to remember that there are multiple drug classes used in both the acute and chronic management of asthma. Understanding which classes to utilize for quick symptom relief versus daily symptom prevention is an essential part of effective management. In the next lesson, we'll discuss how we step up and down therapy based on your patient's level of asthma control. Now, go visit the practice section to reinforce your understanding of asthma pharmacotherapies.